All right, welcome. Today we're breaking down the essential national guidelines for rabies prophylaxis from 2019. For any medical professional practicing in India, understanding these guidelines isn't just a nice to know, it's an absolute must for saving lives.
Okay, let's dive right in. This is the official document from India's National Center for Disease Control. You can think of this as the gold standard, the most up-to-date, evidence-based consensus on how to handle potential rabies exposures. We're going to walk through this with a really clear, clinical workflow. We'll start with the basics of the disease itself, then get into the nitty-gritty of treatment protocols and vaccine administration. We'll also cover those tricky, special cases, and then we'll wrap it all up with a super quick summary, the stuff you absolutely need to remember.
First things first, before we talk about treatment, we have to understand the enemy.
Let's be crystal clear about this because the stakes just don't get any higher. This is the central, terrifying truth of rabies. Once a person starts showing symptoms, the disease is pretty much 100% fatal. And that right there is why getting post-exposure prophylaxis right and getting it right fast is one of the most urgent things we do in medicine.
All right, so how do we fight back? That brings us to post-exposure prophylaxis, or PEP. These are the immediate, critical actions you've got to take the moment someone might have been exposed.
The whole strategy for PEP rests on three pillars. Think of it like a three-legged stool. First, immediate wound care. Second, passive immunization with something called rabies immunoglobulin. And third, active immunization with the vaccine. If one of those legs is wobbly, the whole thing fails. You have to get all three right.
Okay, look closely at this, because this table, this is your clinical roadmap. It's the absolute heart of your initial assessment. Your first job is to correctly categorize the exposure. So what are we looking at? Is it category I, maybe just a lick on intact skin? Is it category 2, a minor scratch with no bleeding? Or is it the big one, category 3, a bite that breaks the skin? How you answer that question dictates everything that comes next.
The very first step, and honestly you could argue it's the most important one, is aggressive wound care. And I mean aggressive. We're talking about washing that wound with soap and running water for a full 15 to 20 minutes. That's all about mechanically removing the virus. Then you follow up with a chemical killer like povidone iodine. And just as important is what not to do. Don't touch the wound with your bare hands, and please never let anyone put things like soil or chilies on it. That just makes things worse.
All right, step 2, passive immunization. This is where rabies immunoglobulin, or RIG, comes in. It's like calling in the immediate reinforcements. You're giving the patient a dose of pre-made antibodies that go to work right away, neutralizing the virus at the wound site. This buys us precious time while the vaccine gets the patient's own immune system fired up. And for any category 3 exposure, this is non-negotiable.
Okay, so you've got two main types of rig to choose from. There's EREG, which comes from horses, and HREG, which comes from humans. You absolutely have to know which one you're using because the dosage is totally different. For EREG, it's 40 international units per kilo. For HREG, it's half that, 20 international units per kilo. Get that calculation right.
Okay, this is a super important point about timing. You have a window to give RIG, and it's a hard cutoff. It is not recommended if it's been more than 7 days since the person got their first dose of the vaccine. So why the cutoff? Well, by day 7, the vaccine has already started kicking in and telling the body to make its own antibodies. Giving RIG after that point is just a waste of a really precious resource.
And that brings us to the third leg of our stool, active immunization. This is where we really empower the patient's own body to fight back using modern vaccines. Let's talk about the different ways we can give it.
So this slide gives you a great visual of the two ways we can go. Over on the left, you've got the intradermal, or ID route. That's where we inject tiny amounts of vaccine just into the top layer of the skin. And on the right, you see the more traditional intramuscular, or IM route, a single, deeper shot into the muscle. So let's put them side by side. The ID regimen means 4 visits for the patient, while the IM route is 5. But here's the game changer with the ID route. It saves a ton of vaccine because you're using such small doses. This makes it way more cost-effective, which is huge. And that's exactly why the National Rabies Control Program is really pushing for the ID route whenever possible.
Okay, a few key points on administration that you just can't mess up. First, the cold chain is everything. Keep the vaccine between 2 and 8 degrees Celsius. Don't let it freeze. Once you mix it, you've got about 6 hours to use it. The right spot for the shot is the deltoid muscle in adults or the thigh in babies. And here's a big never. Never, ever inject into the gluteal region. The vaccine just doesn't get absorbed properly there.
Okay, so we've covered the standard playbook. But, real life is messy, and patients don't always fit into a neat little box. So let's talk about a few of those tricky scenarios you're going to see, like re-exposure or patients with weak immune systems.
So what do you do when someone who's already been fully vaccinated gets exposed again? Well, it's actually much simpler. If it's been less than 3 months since their last full course, just clean the wound and you're done. If it's been more than 3 months, they just need 2 quick booster shots, one on day 0 and one on day 3. And the big takeaway here? No RIG needed. The body's immune memory just needs a little kickstart.
Now, this is an absolutely critical point for patient safety. If you have a patient who is immunocompromised, maybe they're on long-term steroids or have another condition that weakens their immune system, you cannot use the intradermal route. For these folks, you have to use the full 5-dose intramuscular regimen. No shortcuts. It's the only way to be sure they mount a strong enough immune response.
And last up in our special scenarios is something called PrEP, or pre-exposure prophylaxis. Now, this isn't for just anyone. This is for people whose jobs put them at high risk. Think vets, animal handlers, lab workers. It's a simple 2-dose series. It doesn't mean they can skip treatment if they get bitten, but it basically just simplifies things massively if they ever do get exposed.
All right, we have covered a lot of ground, so let's boil it all down to the absolute essentials. This is the stuff you need to have locked in, ready to go in a real-life situation.
Okay, let's run through a rapid-fire mental checklist. First up, categorize that exposure. Is it 1, 2, or 3? Get it right. Next, wound care, wound care, wound care. Wash it like you mean it. For any Category 3 bite, it's a combo deal. They need both RIG and the vaccine. Remember, the ID route is preferred, it's cost-effective, and it works. But for anyone immunocompromised, you must use the IM route. And finally, if someone's been re-exposed after 3 months, it's just 2 simple boosters. That's it.
So, that's a wrap on the national guidelines. And think about this. Rabies is one of the few diseases out there that's pretty much 100% fatal, but also 100% preventable after an exposure. So it all comes down to us. The outcome rests entirely on timely, correct clinical action. The question you have to ask yourself is, are you ready?